Welcome everybody. My name is Jonathan Schofield. I'm Deputy Director of Cascade Centre, which is organising these exchange events. Great to have you here to listen to Dan today. Dan's going to talk about social work in hospitals, and it's worth me saying, just by way of introduction, that there's very, very little research ever been done on social workers in hospitals. So this is, in that sense, this is a very original, groundbreaking piece of research, and I know about it already, but I'm sure you'll find it interesting. And there is also a book, so hopefully Dan will plug the book, and those of you interested can go off and buy it. So without any further ado, Dan, I'm going to hand over to you, and I'll come back in to field questions at the end. Probably people know that the drill will be to write questions in the chat box, please. I think as a rule, we'll just let Dan speak uninterrupted. And then we'll take questions after he's done. So how long will that be, Dan, roughly?
Aiming to talk for about 40 minutes and then questions after that, if that's okay.
Okay, so we'll let Dan do his business, and then we'll take questions that people put in the chat after that. Feel free to put them in the chat now if you want to, but we'll come back to them when Dan's finished. Okay, so to welcome Dr. Dan Burrows, social work lecturer in Cardiff University, and over to you, Dan.
Okay, thank you very much. So this should be going into slideshow now. Yeah, there we are. So yeah, thank you. It's lovely to have the opportunity to talk to everyone about what really is my favourite subject, hospital social work. To give a bit of background to this study, as a social work practitioner myself, I did a role in a hospital. It was a sort of quite a niche role, working in the Children's Hospital on the Children's Cancer and Leukemia unit. And when it came to doing some research on social work, I decided I wanted to focus on hospital social work, but to look at a different aspect of social work, of hospital social work. So this, the study that I carried out is really focusing on the sort of hospital social work teams that focus on discharging older people primarily, making plans for older people to leave hospital. So that's what we're focusing on today. So I think it is worth just quickly looking at the history of hospital social work, because I think it's quite instructive when we think about social work as a profession or a would-be profession, and what and how we got to where we are. And actually, the hospital social work has quite an interesting and checkered past, really. We can actually pinpoint when hospital social work started up. Initially, the role was called the almoner, or it was often referred to as the lady almoner. And these almoner posts were created to assess hospital patients' eligibility for free care, starting with the first one in one of the free hospitals in London in 1895. And these posts were originally born of a concern that people were abusing free hospitals, particularly the outpatient clinics of free hospitals, because they didn't want to pay for a doctor that they could actually afford. So, you know, this sort of theme we have in British social policy of being sort of paranoid about people inappropriately claiming benefits and welfare goes back quite a long way. But the almoners that came into the post quickly expanded the role. So rather than just looking at people's financial circumstances and assessing can you pay or not, they started following this ambition to assist doctors to understand the social causes underlying disease and to remedy such causes. And so a lot of their role from very early on became focused on ensuring that a patient could get the most possible benefit from medical treatment. And I think stats seem to suggest that they approved the free treatment of around at least 3/4 of people with whom they dealt. But this ambition that hospital social work had, or social work had in its early days, to sort of be a social version of medicine. So to use a kind of a diagnosing medical gaze, I think can particularly be seen in the work of Mary Richmond on social diagnosis. And we can see other ways that hospital social work tried to professionalize. So it was the first branch of social work to have a professional association, for example. And in fact, in the early days of the 20th century, it actually had two professional associations. Okay. So it did have some a reasonable amount of influence in the first half of the 20th century social work in hospitals. Things like sanatoria and convalescent homes, which were often set up for TB patients, for example, were linked to the influence of almoners, pointing out the difficult social conditions that many people were living in. And up until the mid-20th century, and probably up until the 1960s, almoners, or medical social workers as they became known, had an active role in medical training. And in particular, they would accompany doctors on ward rounds. And when medical students were being told about the physical needs of the patient, at the same time, the almoner could chip in and talk about their social circumstances as well. So trying to increase doctors' awareness of the social causes underlying many diseases. And so, you know, as the history of the 20th century unfolded, medical social workers tried various ways to sort of respond to what was going on. So, for example, they claimed a role in supporting families when soldiers came back from the Second World War and brought sexually transmitted diseases with them. So they helped families to deal with the sort of the social consequences of those sorts of things. And their professional power can be seen in their things like their ability to resist being registered as a profession auxiliary to medicine. There was a lot of objection to that sort of term and being seen as subordinate to doctors. And I think actually in looking at modern hospital social work, the idea of being free from the influence or from the instruction of doctors is quite an important one in hospital social work. Hospital social workers or medical social workers had their own professional qualifications and their own courses that were based in universities. But the second half of the 20th century really sees a waning of the professional power of hospital social workers. So particularly the NHS, the creation of the NHS brought about new public health professional roles, and these undermined the place of medical social work. So things like health visitors and community midwives started to replace some of the roles that hospital social workers or hospital-based social workers, medical social workers, would have been doing based in midwifery and obstetrics. And then, of course, in the 1960s, we had the genericization of the social work role. So all the different branches of social work coming together to be one profession, and the creation of one professional association, the British Association of Social Workers in this country. And that rather diminished the prestige of medical social work, as it was called. That sort of diminishing of the professional power and prestige of the medical social worker really continued with the community care reforms under the Thatcher and Major governments, where social workers were set up to be brokers of services. So you know, the idea of community care is that the social worker assesses a need, designs a package of care, and then is a broker of who is going to provide that service for the person. Now, that role in particular became more and more prominent in hospital social work. So whereas hospital social workers had been doing a lot of work directly with patients to support them on the social and psychological consequences of illness and disease, more and more their job became involved in planning care for people who needed to, when they were ready to leave hospital. So more and more, the hospital social work role over the 1990s and into the 2000s became very heavily associated and very strongly associated with discharge planning. And what we've seen, some of the currents that we've seen in social work over the last 20 years, and I think particularly managerialism and bureaucratic control of social workers have been particularly prevalent in determining how hospital social work is carried out. So, and that's all taking place within ever diminishing resources, certainly since 2010, not only ever diminishing resources, but increasing demand for social work and social care services. So what modern hospital social work tends to be now, and as I say, this is for the mainstream hospital social work teams that most hospitals have based within them. Not all, some local authorities don't place teams within hospitals, but most local authorities will have a dedicated and specialist hospital social work team. The role is characterised by enormous pressure from managers, both within social services and within the hospitals, and from clinicians to discharge patients quickly. And it's like standing in a river. The different work is coming all the time, and you never really can get ahead of demand. By the way, I use the term clinicians basically to cover anyone who's sort of patient-facing in the NHS. So I'm talking about doctors, nurses, physiotherapists, occupational therapists, speech and language therapists, among others. So discharge really is the central focus of social workers. And what we see is that social work practice in hospital has become more reduced to a succession of bureaucratic tasks. And it's bureaucratic in the sense that, that social workers are exercising power on behalf of people to distribute resources. So coming to my study then, and as Jonathan said, yes, there is a book which expands on the topics that I'm covering in this webinar today. So I carried out an ethnographic study of a hospital social work team, and this was the thesis component of my professional doctorate. So I spent a total of 6 weeks that was spread out over a period of a few months. I spent a total of 6 weeks observing social workers and clinicians in one particular hospital. When I set out to carry out this piece of work, I was hoping as much as possible to accompany social workers in their direct contact with patients and carers. And I had some access to seeing that going on and to talking to patients and carers, but limited access. So this ethnography tended to be a much more behind the scenes, sitting in offices, sitting in meetings and so on with people. But alongside the observations, I also carried out interviews with social workers, clinicians, carers, and patients. So there was quite a range of data collection methods that went into this study. And just to say with the book, the hardback copy of the book is very expensive indeed. So do look at getting the ebook Kindle version if you did want to buy a copy. So anyway, to talk you through, I think there are sort of 3 headline findings that I took away from my study, which I'd like to talk to you about. And the first key theme really is the bureaucratic nature of social work in hospitals, and the extent to which social work in hospitals has been made to reflect the priorities of governments whose ideology is primarily neoliberalism, which means, of course, that state services should be kept to a minimum and only targeted at the most in need, and also that that practices from the private sector, so use of things like key performance indicators and so on, and performance data should be used to make state-delivered services as efficient as possible. And when I was analysing the findings, and I was looking through all my ethnographic data, I stumbled across Bauman's work, Modernity and the Holocaust, and it really struck me that some of the conditions of bureaucracy that Bauman argued made something like the Holocaust inevitable are actually still present in the way we are running state services, and in particular, social workers argued that that the Holocaust was made possible because of bureaucracy, because it became easy for an official to sit in an office and to sign a piece of paper and to take no real moral responsibility for the action that had been specified on that piece of paper, because essentially they weren't going to be the one face to face doing something. And then for the next person to come along who was responsible for carrying the order out, well, it wasn't their decision, and so on. So there was this sort of separation between the order of the action and the action itself. And we see this actually in community care practice in general in social work. The way that social workers, they go and assess a person's needs, and they would then recommend or create a care plan. That then has to be sent to a manager and on to a senior manager for approval. But actually what we see is that the person who is responsible for approving or denying that care plan never gets face to face with the patient. So it's a lot easier. It's an efficient way of looking at resources, but essentially it removes the moral burden of actually denying someone a service from the person who potentially would deny them if they decide not to approve. What I also saw, I mean, looking at the outputs of hospital social workers in terms of the care plans, they were very, very focused on eligible bodily needs. So they tended, there was a sort of a slightly dehumanizing element in the way that the systems required the social workers to produce outputs. So when you read a social worker's assessment or you read a report, you didn't get a sense of the human being behind the care plan. All you got a sense of was this is what is required within this care plan. And also because of the huge amount of pressure on social workers to carry out discharges as quickly as possible, you would see some corner cutting. So for example, people attending best interest meetings without really having met the patient, for example. And they certainly can do a job of upholding someone's rights to have their needs and views considered, but they hadn't spent time with the patient very often before going to do that. And we also saw some Fordist or Taylorist approaches, and I drew on the work of Donna Dustin, the McDonaldization of social work, in looking at some of this, but how Fordism relates to the the sort of the factory assembly line approach of everything being the same. And I think overall hospital social work teams tend to have a Fordist tendency in the sense that everything has to boil down to a care plan. The social workers are there to do a care plan. If the solution to a problem isn't a care plan, then it's seen as the patient needs to go elsewhere for their help. And it's also Taylorist. Taylorism relates to the idea of efficiency and time and motion studies and so on. And there are ways that we see Taylorism creeping in here. For example, separating POVA investigations, having a separate team to lead POVA investigations and so on, while the social worker carries on with the care plan, although of course they feed into the POVA. But so I think the really important point that I want to make about this is that these are system driven, these are procedurally driven constraints on social work practice. But actually what I saw in practice is that social workers don't have a personal stake in the performance data, and therefore they always still have a loyalty to the patient, and they do retain a certain amount of discretion, and they use that discretion very often on behalf of the patient. So having thought about these bureaucratic and neoliberal systems, I thought about, well, how is this work still social work? And if you're familiar with the IFSW description of social work, you know that it's pretty ambitious and all-encompassing. that talks in very hopeful terms about social work being a force for social change, that doesn't really fit the model of what we see in a role like hospital social work, where the work is very much focused on the individual and on providing a service to the individual, and not necessarily thinking about the wider social forces or structures involved. So when I was thinking about, well, to what extent is this discharge planning work that hospital social work teams doing? In what sense do we really feel that it is social work? I sort of feel, I kind of boiled it down to a regard for human rights, a regard for social justice, and an ambition for the empowerment of people that we're working with. Those are sine qua non of social work. Without those things, it isn't social work. And actually, each of those tenets can be seen in the practices of the hospital social workers, but they tended to be focused very much on the individual. So, for example, a social worker certainly would be protecting the human rights of an individual patient in the hospital, but they wouldn't necessarily be talking the language of human rights or talking about ways to change wider systems or structures in favour of people's rights. But certainly on the individual level, they would focus on human rights, and certainly on social justice as well, on making sure people were able to access what they needed. That very much is part of the hospital social workers approach, certainly the social workers with whom I spent my time. And what was really interesting actually was, for example, if you take a social worker makes a recommendation for a care plan, it then gets sent to managers for approval. If it comes back and it hasn't been approved, the social workers, generally their attitude wasn't that, oh, well, unlucky, we haven't been able to get that through, or, oh dear, well, I haven't understood the eligibility well enough here. They would see it as a challenge. I need to get more information in order to justify this plan. And they would go away and they would get more information until they did get their plan through. And certainly empowerment was something that I saw very central to social workers' sense of what they were trying to achieve. And they really saw themselves as advocates for patients, and particularly patients for whom there wasn't any question over their mental capacity. They were very keen to ensure that whatever they said they wanted, that was what, as far as possible, would happen. And sometimes that would mean that they would advocate for patients to the rest of the medical team who were saying, oh, no, their needs are too great. They need, often the sort of classic scenario was a patient saying that they wanted to go back to their own home. And clinicians might be saying, well, there's an awful lot of risk involved with this. Family members might be saying, family members often just wanted to see their loved one as safe as possible, and therefore would be favouring heading towards residential care. But the social workers would make sure that they took time to establish what the patient, what the person in the middle of that discharge plan really wanted. And that they would then, if they needed to advocate to their family or to other professionals on their behalf, they would take that on and they would do that. And that was something that they really saw as central to their role. And even in the case of where we were talking about people who didn't necessarily have the capacity to make the decision about discharge, very often social workers were still keen to think about, well, actually, what is going to make them happiest? So still thinking about their wishes and feelings. So all of those things, human rights, social justice and empowerment, they're all there within these practices. And actually in their day-to-day work, I did hear social workers talking about this in these terms. As I say, they didn't use the language of human rights, but they did think very much about people's natural rights. caveat I would say to this is that this still tended to be a highly individualistic approach. So that they were thinking very much about people's negative freedoms, the right to be free from interference unless it's absolutely necessary. Social justice for the individual, so not tackling systems, and empowerment very much at the individual level. And examples of this, for example, I remember seeing a social worker come into the office really cross. A hospital patient she had been, or he had been assigned to, had been moved to another ward, and the patient's Zimmer frame, walking frame, had been left behind. And the other social workers commented, well, in no time at all, that person isn't going to be able to walk, because what will then happen is, because the walking frame isn't there, the patient will be taken on will be wheeled to the toilet, for example, rather than walking for themselves, and so on, and they'll lose muscle tone and so on. And the social worker said, no, I'm not going to let that happen, and went around the hospital and hunted the walking frame down and transferred it from one ward to the other. So very much that's about preserving the individual. But that social worker didn't think about, making any sort of complaint or raising a concern that this had happened. There wasn't a sense of wanting to tackle the wider systems within the hospital that were allowing this sort of mistake to go on. So very much the practice was focused just on that individual. So quite a blinkered focus on the individual, but certainly thinking about that individual's access to human rights and social justice, and certainly wanting to enable the conditions to occur in which empowerment could be allowed to happen. And so then the third and final theme that I was particularly interested in was thinking about the dramatization and visibility of social work within the hospital. And I drew particularly on Goffman's insights in this regard. So Goffman observed that whenever we do anything around other people, we not only do it, but we dramatize doing it. We make what we are doing visible to others. And the wonderful thing about being in and around hospitals is how much dramatization of everyone's work is going on at once. But what was really interesting is that the dramatization of social work was much more low-key than other professions. So for example, this particular social work team was in a ramshackle and isolated office that no one else came to. There's a certain lack of visual emblems for social workers compared to pretty much all the other professionals in a hospital. So for example, nurses, physiotherapists, occupational therapists would all have their particular uniforms, so you could tell visually straight away that someone was a nurse or a physiotherapist. With doctors, you tended to see that the more junior doctors, they didn't have a uniform at the time in the hospital I was in, but you could tell they were a doctor because they had their stethoscope around their neck at all times, always wore the stethoscope. The more senior doctors, they'd stopped wearing I guess when you become a certain level of doctor, you stop wearing a stethoscope and you instead start dressing a little bit more smartly, so with a suit with or without a tie, but to make sure everyone knows that you're still someone very very important that can be called on any time. They have their pager very visibly on display. By contrast, social workers would come and go from the wards, and they, you wouldn't necessarily know that they weren't a member of the public, other than possibly you often see a social worker holding a diary that's got lots of bits of paper in it and maybe has an elastic band holding it together. But yeah, so that dramatization of the role, going in and talking to a patient, was done in a much more low-key way. And of course, if you think about the idea of dramatization as Goffman does, then each area in which we perform our roles in front of others can be thought of as a stage. And actually, when social workers are going into hospital spaces, they're often they're not in command of hospital spaces in the same way that other professionals are. So there's this lack of command. There's almost a sense of going into someone else's territory. And it was really interesting thinking about this low-level visibility. On the one hand, it certainly led to mistrust by clinicians. So there was this sort of complaint that you never get to see the social workers. But actually, it was functional to social workers in ensuring that they weren't overwhelmed with work, because what tended to happen is once a social worker was contacting a patient on a given ward. Now in this team, the social workers didn't have allocated wards, so they worked all across a very large hospital. So what you would see happening is if there was a patient on the ward had a social worker, and clinicians, nurses and doctors became aware that there was a social worker involved with a patient, they would then start to contact that social worker about other patients. They wanted that social worker to be their ward's social worker. So actually this kind of low-key visibility meant that social workers could kind of, almost come in under the radar into wards and out of wards without getting sucked into things, because the volume of the work was so high and the pressure to get discharges done was so high that they needed to have very careful strategies to manage their work. So as I was thinking about the relationships between hospitals, social workers and clinicians, I turned to Goffman again to think about how everyone understands socially what's going on in any particular situation. And Goffman gives us this theory of frame analysis, which is about how we make sense of social situations. So in any social situation we go into, we have a frame of understanding what our role is, what the other person or other people's role is, and what's going on here. And we have a sense of the rules of the game. These all sort of encompass a frame. So I suppose, a very basic kind of explanation of a frame analysis is if you think about throwing a punch. If you throw a punch in a game of rugby, that's foul play, but you're unlikely to be arrested. If you throw a punch in a pub, you're much more likely to be arrested. And that's all about the frame, the social situation, and all the rules of the game and the underlying assumptions that go with it. So what I noticed that clinicians within the hospital of whatever professional background tend to share roughly the same frame, and it's a frame in which there's this really complex negotiated hierarchy, but in which the consultant physician, so the most senior doctor, is always at the top. Now, clinicians see social workers as part of this hospital social work order, as part of this social order, but social workers see themselves as being outside it. And in particular, this idea of being patient advocates is crucial to them seeing themselves as sitting outside the order and working for a different bureaucracy. Most social workers are working for a local authority. That helps them to maintain this distinction. And of course, the discrepancy between frames can lead to conflict, which obviously is something that as an ethnographer I was very keen to explore. So I'd like to just share some field notes that just demonstrate three different ways that conflict was dealt with between social workers and clinicians. So the first one, this is a social worker describing an occasion of conflict she experienced with a doctor. And she's talking about a patient who wanted to return home upon discharge. The clinicians in the hospital felt that he had the capacity to make this decision. And it turned out when the social worker talked to him, she felt he didn't. The family were concerned. The family also felt he didn't have the capacity to make this decision. So the social worker says, there was a gentleman, from the first day I met him, I felt he didn't have capacity with regards to discharge destination because he couldn't retain information, he wasn't able to weigh up any risks, and we did a risk assessment with him and his responses were just completely inappropriate. whereas the doctor thought he had capacity. I challenged him on this, and his response was, "Oh," he called her by name, "I have no doubt in my mind that he has capacity." And I said, "Well, I'm sorry, but I disagree. I'll come back and visit him in a few days." I went back. I was still adamant he didn't have capacity. The doctor was adamant he did, and the gentleman started deteriorating. And it took about 6 weeks, and the doctor actually said he doesn't have capacity. Whereas this gentleman had gone from residential to needing a nursing home and now CHC. And the family had actually chosen a residential home that they thought their father would be happy in, but now he couldn't go. And in talking about this, this particular conflict, the social worker reports that she, when speaking about this to the doctor, said, "I challenged him on one of the domains, and his response was, 'We need to get somebody more senior than yourself to attend this meeting.'" So I think what this example really shows is how social workers and physicians can just get at loggerheads. They can just get stuck because they don't have a shared sense of each other's roles and each other's levels and limits of responsibility. So there's almost a turf war going on here. And in this particular case, I mean, this turf war, I mean, this is quite an unusual situation, but this turf war ended up being quite detrimental to the patient in the sense that a plan wasn't made for him. And so he waited several more weeks before eventually being discharged. A contrasting way of dealing with conflict is shown here. So this is a social worker reporting back on a meeting regarding continuing healthcare. And just in case you're not aware of continuing healthcare or CHC, what it means is essentially continuing healthcare, CHC, is funding for care that is provided by the NHS, that therefore isn't means tested, whereas services provided by the local authority are means tested. So CHC tends to be given where people have particularly complex medical needs that are going to require ongoing long-term care. And to agree whether a person should or shouldn't have CHC, social services and the NHS need to come together, assess the needs and come to a decision. In this particular meeting, the social worker and the clinicians were not able to come to a shared agreement on is this patient eligible for CHC or not. And the social worker reported, "So she, the chair of the meeting, kept saying to me, 'We're in dispute.' I said, 'Well, I'm not in dispute, I just have a different view.' But she kept coming back to this saying, 'We're in dispute,' as if it was something very dramatic. So I said, 'Well, what does that mean?' And it just means that all the paperwork gets sent up to the next level for a decision. Well, I don't mind. If the decision goes against me, so be it. It's up for the family to appeal. I'm not going to get excited about it, not as excited as the chair was anyway." So again, we see here again the social worker being quite prepared to buck the system and to challenge medical or clinical authority. And what's really interesting is this time this is a demonstration that there are actually mechanisms in place to resolve these disputes. And essentially what happens is things get escalated to sort of team manager or service manager level on the local authority side and to hospital manager level on the NHS side. So essentially, again, we see this kind of this bureaucratic separation then of the decision maker from the moral consequences of this decision. And finally, I thought this was a really interesting, this was another CHC assessment meeting that I attended. And what was going on here was that the doctor and the nurse in question didn't feel that this patient would qualify for CHC. The family were very keen for him to have CHC, and of course the social worker wanted to support them in that. So the first extract here, Dr. Four emphasises he does not think the application has any chance of success with the panel and therefore feels it should not go ahead. The social worker asks, aren't all his needs in the nature of his illness? Dr. Four says insistently, that he is a Parkinson's specialist and he would say he is in a complex stage, but he does not need extraordinary nursing care. The social worker questions this. The illness is causing his nursing care needs. She turns to the family and asks them if they want to apply. The doctor says he does not want to waste time. And what was really, really interesting in this moment was that the social worker physically turned her back towards the doctor, who was sat on the table that side. Family were over there, and she turned away and she faced the family and said, "What do you want to do?" And again, it was that assertion that the social worker is the patient or the carer's advocate and is not subordinate to the doctor. Now, what eventually happened was that, again, we reached a sort of a situation where the social worker wasn't really in agreement that this patient should have or should or shouldn't have CHC. I think the doctor said no. The social worker, I think, would have tended towards yes. But rather than escalate this into some sort of dispute resolution, the social worker came up with a way around the issue. And so what happened was, as soon as everyone else had left this meeting and the social worker was left with the two family members, myself there as the observer, as soon as the nurse is gone, the social worker advises the family members to wait and get a new CHC assessment once the patient is in the community. She says the community nurses are much more thorough and more likely to get the sort of detail needed to get this through. So what we see happening there is, again, the social worker not accepting medical authority, but on this occasion, rather than going down the route of dispute resolution, which might take considerable amount of time, and she didn't necessarily have much faith in getting a favorable outcome for the patient, she took a sort of a let's take the longer game, let's take a sort of a strategic approach to this. I should say, of course, that there's a lot of work goes on, as well as all this conflict, there's a lot of work that goes on to produce harmony as well. So social workers do openly challenge senior doctors, and that is seen as a violation of the hospital order. And part of what's going on is social workers are asserting their loyalty to a separate bureaucracy, even though they have to manage the pressures from both. But a lot of work is done to maintain harmony. So there's sociable demeanour, the use of humour. And what you also see is where there are patients or family members who feel like a threat either to clinicians or to the social workers, there tends to be this closing of ranks, and social workers, I saw them, carrying out work basically to get closer to clinicians to deal with this sort of threat. But there is also this element of social workers having a sense of needing to pick battles. So I just wanted to...
Dan?
Yeah?
Dan, sorry, just a bit of timekeeping. Just to note, it's 2:45, so it's been about 40 minutes, and we need to finish at 12. So just you might want to round up if we want to allow time for questions. Okay.
Yeah, sure. This is my last slide now, and I just wanted to point to some ideas for the future and to really emphasise clinicians in hospitals really value social work highly. And one thing that I was struck by is the clinicians want more social work. In this country, we tend to focus on speedy discharge, but this masks other important considerations, in particular, readmission rates. And there's a lot of work, there's some references on the screen there. There's a lot of work coming out of America and Australia to say that social work interventions can be effective in reducing readmissions, but this has to be more than just care planning. This has to be really thinking with people about managing their longer term health needs. So I think, we're seeing a model of health coaching that could well be adopted and adapted by social workers in health related settings. And I think there's a strong match between health coaching and common social work approaches and techniques. So things like strengths-based work, solution-focused work, task-centered work, all of those things I think can feed in. And so what I would say is that hospital discharge work, I think it's really important that it keeps being done by social workers. But I think we're missing a trick, and that social work could offer a lot more in hospital, and I think we need to have a lot more social workers in hospital. So I'm going to stop there and take some questions.